Hello, ladies and gentlemen, my friends and teachers. Myself, Dr. Pankaj Patawari, consultant at Sun Valley Hospital, Guwahati. Today, I'm gonna discuss a case of Mrs. Kamal. She is a college professor, 54-year-old female with type 2 diabetes since 4 years. During routine checkup, the complaint of generalized weakness was there, and she was hospitalized for acute coronary syndrome 1 year ago and went through PTCA. It is a family history that the father had an MI and underwent CABG surgery 5 years ago. So this is a typical case which we often come across in our day-to-day OPD. A lady with a BMI who is obese. The BMI is around 29.7, and the blood pressure is on the higher side, 146 by 86. HbA1c also on the higher side, 8.4. The LDL is 75. HDL is 37, so lower on the lower side. Triglyceride is 156. Total cholesterol 168. eGFR 65. Urine ACR is 300, so very high. That's the cardiac risk factor. In 2D echo, there was a mildly dilated LN RA. So she was on metformin means treatment like metformin 1 gram BD, glimepiride 4 milligram OD, and for the pressure she was on losartan for 50 milligram OD. For the cholesterol part, she was on atorvastatin 40 milligram OD. For the pressure part, she was also receiving amlodipine, chlorthalidone, and she was also receiving metoprolol extra 50 milligram and aspirin 75 milligram. So we can see that she was a sedentary lifestyle and she is trying to avoid weight gain and exercise a few times a week. She is frustrated that her weight is unchanged and now she reports occasional hypoglycemic events as well. So we can very well make out which medicine would have been the cause of hypoglycemia. So the challenges in this patient is she has uncontrolled hyperglycemia, she is obese, she has hypertension, she has a previous history of MI, she has albuminuria. Plus, what is the risk status of this patient if you have to find out? She will be falling in the very high risk category because she is young, diabetic, she has multi-organ target damage, and she had already a history of acute vascular event. And individualization of HbA1c target must be there. And the weight gain due to less physical exercise is also a risk status. So now coming to discussion. So type 2 diabetes is a complex disease. Chronic hyperglycemia is the cause which gradually increases over time. And type 2 diabetes is associated with other severe risk factors such as abdominal obesity, hypertension, dyslipidemia, thrombogenetic state, low-grade inflammation, oxidative stress, which all where most of things were present in our case. Almost seems like a metabolic syndrome. So these risk factors accelerate atherothrombosis and results in cardiovascular disease, that is coronary heart disease in the form of MI, stroke, peripheral artery disease. And almost 2/3 of patients with type 2 diabetes will die from cardiovascular disease. And almost so better management during the last 2 decades allowed reducing the incidence of severe complications, yet the residual risk remains high in patients with type 2 diabetes. Another factor like CKD remains a concern, area of concern, and heart failure becomes a complication of major interest, both at least partly due to the reduction in premature death among type 2 diabetic patients. So the ADA recommends 2019 CV protective agent as first line as add-on to OHA in case of CVD in patients with type 2 diabetes. And in fact, in the 2015, the era of evolving dimension of cardiovascular care in type 2 diabetes management began with the EMPA-REG outcome study, which demonstrated significant benefit of empagliflozin in the risk of heart failure reduction by 35%. Among participants with a baseline history of heart failure, EMPA was associated with a numerically lower rate of hospitalization for heart failure. The hazard ratio was 0.75 and the CV death hazard ratio was 0.71, with no heterogeneity between participants with and without baseline heart failure. So among participants who had an initial history of heart failure, EMPA was associated with a near twofold reduction in the risk of subsequent CV death or hospitalization for heart failure. So now it is possible that SGLT2 inhibitor might prevent the development of heart failure in diabetic patients. The top line results from EMPA-REDUCE have been recently published in patients with heart failure with reduced ejection fraction without diabetes. And the EMPA Heart CardioLink 6 study demonstrated that EMPA could produce early reverse. It could reverse the cardiac remodeling in type 2 diabetes and stable coronary artery disease. So in the sub-analysis from the EMPA decreased the new onset of worsening of nephropathy by 39% on top of RAS blocker. So the addition of EMPA was associated with slower progression of kidney disease. So the CV and the renal benefits seem to be maintained independent of the eGFR level, even with progression of eGFR decline. So because of the unique mechanism of action, SGLT2 inhibitors have a range of effects that may translate to potential benefits beyond glycemic control, especially in diabetes, kidney disease patients. So the pleiotropic effect, including the reduction in blood glucose, natriuresis, decrease in blood pressure, body weight changes. It confers a protective effect on the kidney by reducing the severe renal risk factor in type 2 diabetes patients. Another group of drugs like the gliptins. Among the one is linagliptin. It is a unique profile with a primarily non-renal but hepatobiliary route of elimination, so requiring no dose adjustment in patients with CKD. And Carmilla study, which is a linagliptin CV outcome study, confirmed that lina reduced the progression of albuminuria by 14% and reduced the risk of progression of albuminuria. The hazard ratio was 0.86. So the combination of EMPA and lina, it offers a suitable component in strategy to achieve target HbA1c without hypoglycemia and weight gain. So the add-on to metformin trial confirmed hypoglycemic adverse events occurred with an incidence of 2.2 and 3.6% with EMPA-LINA combination. So the reduction in the incidence of genital infection associated with SGLT2 inhibitor have been reported when a DPP4 inhibitor is added. So there's an added advantage, perhaps because of a better glucose control, although other possible mechanisms remains to be investigated. Additionally, it would reduce the daily pill burden in this population, improving adherence and optimizing the benefits of treatment of diabetes mellitus. With this, I'd like to thank you.